much. Good afternoon. In the next 20 minutes, basically, I'm going to really talk about very important hot topics in the last few years. But unfortunately, as internal medicine, the majority of us is really not following the guidelines. And I think that's affecting our patients. So hopefully, at the end of my talk, it will be eye-opener for us to do better. And if all of us are doing the right things, then hopefully we'll continue to do that. So we know that diabetes is something we deal with every single day. And we know that CKD affect about 2 out of 5 people with type 2 diabetes. So this is something very common we're dealing with in our practice. So if you can see this case, this case was 66-year-old female was consulted by her daughter, who's a physician, because the patient and the daughter is very concerned about her worsening renal function over the last couple of years. And you can see the patient is asymptomatic, but the patient has type 2 diabetes and hypertension for almost 6 years. She's diagnosed with CKD. She has OA and IBS, strong history of diabetes, hypertension, and CAD, sedentary life. And you can look at her medication, and please, by looking at her medication, do you think she's getting appropriate treatment? So she's already on a high dose of ACE inhibitor. She's already on SGLT2 with metformin, also the highest dose. She's on aterva and aspirin. So, and you can see on the lower side, this is her eGFR over the last 2 years, which is declining. So, so that's a question from the patient and her daughter, and this is what I will address in this topic. So is there any other treatment option to stop or reduce her CKD progression? And that will also, in that topic, in the 20 minutes, I will talk a little bit about the importance of renal protection and also, of course, cardiovascular disease protection in patient in type 2. We try our best to prevent or delay or slow the progression of CKD and, of course, to keep our patient alive. So you can see here that when we have CKD on the top of diabetes, all-cause mortality go very high. Also, cardiovascular death goes high. So if you compare diabetes and CKD to comparing to diabetes alone, there is 3-fold increase in the cardiovascular death. And on the left side, you can see that diabetic kidney disease is much worse regarding progression of the CKD to end-stage renal disease than the non-diabetic one. After that comes the hypertension, and most of our patients, they have both, like this patient. We can also know from previous studies that, you know, the lower the GFR is the higher risk of cardiovascular mortality and morbidity, and also for albuminuria. And you can see here, surprisingly, at level of 10 milligram per G, the lines start going up. So it's not just after above 30 milligram per gram. So as internal medicine, we really try to do our best to, even before the patients start to have CKD, we really need to look at prevention of hypertension and prevention of diabetes by encouraging healthy diet, addressing the weight, and so on. But when we deal with hypertension and, diabetic patient, we all know that we have to screen for CKD in the form of ACR or eGFR, and we do it, but unfortunately, many of us, they don't know what to do next, or they don't do anything else. And you can see, unfortunately, that all the patient needs to be screened 100%. In multiple countries, the screening is not done. Hopefully, we're doing much better in UAE, but hopefully also will do something about it. So it's very well known that it's too late when we send our patient to nephrology. We really need to act as early to protect the kidney, and by part of it, it will also protect the heart and from CKD, from cardiovascular disease and heart failure. And all of this will reduce mortality, morbidity, hospitalization, cost of hemodialysis and renal transplant. So regarding the drivers of CKD progression in type 2 diabetes, we all know about the hemodynamic and metabolic because we've been taught about it, and we're addressing it with the current standard of care. But for many years, we knew about the inflammation and fibrosis, but we didn't have anything to do with it. So that's the reason we didn't talk too much about it. So all of this driver will cause at the end kidney fibrosis and CKD progression, which is very dangerous, as we already showed. So current standard of care, it's really addressing both the hemodynamic and the metabolic drivers. In a way, we need to control the hypertension, the diabetes, the weight, use the ACE or ARBs, use the SGLT2. One of the things I see in the practice, unfortunately, many of the internists or the primary care, they start ACE or ARBs, but they don't really titrate to the appropriate dose. Part of it inertia, part of it maybe not good knowledge or whatever, but really we need to go to the highest dose tolerable to really get the best effect. Until recently, we didn't have any medication to address the inflammation and fibrosis. So you can see here from previous study where now we have the standard of care to use the ACE or ARBs. In the renal study, in the IDNT, there was significant reduction in the progression of CKD towards end-stage renal disease, 16% in the renal, 20% in the IDNT, but there was still residual risk for progression of CKD to the end. Also, when we start getting the SGLT2, we can see here we got better result on the top of the ACE and ARB, but still there is residual risk. That's the reason now, in the last few years, they start looking at the inflammation and fibrosis to see if we can do something about it. And we knew that mineral MR overactivation, it caused at the end inflammation and fibrosis. And recently, we had the medication to really block this overactivation to help our patient more. So phenylalanine, which is non-steroidal MRA, different than spironolactone in different way because of the affinity to the receptors and other things. And the most important things, we can look at the list of things which can differentiate effect on inflammation and fibrosis much greater with the phenylalanine. Effect on renal electrolyte disturbances much less than spironolactone, so it makes it more safer and easy to treat with it. The most important also risk of sexual side effects, gynecomastia and so on, it's not there because it's non-steroidal. Risk of hyperkalemia is a little bit there, but not as bad as spironolactone, and I will address it in the next few slides. Effect on blood pressure, much less than the spironolactone. So something to keep in mind, but it might be a benefit actually for patients with hypertension also. So going back to the case, if we look for the medication she's really on the standard of care. She's on the maximum ACE dose, and she's already on SGLT2. Unfortunately, also, we're really not using SGLT2 as what we're supposed to, but, this patient is already on the good medication, but she's still having deterioration. You can see her blood pressure is well controlled. Her hemoglobin A1C is well controlled. Her potassium 4.6. LDL can be better, so this is something to be addressed with this patient. Echo showed ejection fraction 55%, but you can see her ACR 250 milligram per gram and her AGFR 58. So if you plot her on the heat map by KDIGO, she's grade 3A, A2. And she's really at high risk to develop more progression of her CKD and also for cardiovascular. So This is the question of the patient and the daughter. Anything else we can do? So now with phenylalanine, yes, we can do a better job for this patient. So this patient was started on phenylalanine 10 milligram because her potassium is less than 4.8, but her AGFR less than 60. So this is the starter dose for phenylalanine 10 milligram daily. And you can see after starting, 3 months after, we can see the albuminuria is getting better, about 27% from 255 to 185. Her GFR dropped a little bit from 58 to 55, which is acceptable and reasonable because this is how the medication works. There will be initial dip, but then later on we will see the benefits, similar to ACE and ARB, similar to SGLT2. So nothing really unique comparing with the other. And you can see here by plotting this patient, it really fits the criteria with the Fidelio DKA with the blue. And also it fits the same also with Figaro also. The Fidelio usually was predominantly CKD stage 3 and 4. The Figaro one was 1 to 2 predominantly, but both of them now it will cover CKD from stage 1 to 4. So the design was very appealing in a way. The two study had the same primary endpoint, but in the Fidelio was the renal input as a primary, secondary as cardiovascular. In the Figaro, they switch it. The primary is cardiovascular and the secondary is the renal. And they have a pre-specified analysis to look at all those patients, which almost 13,000 patients later on in the fidelity analysis, which I will also give some result about it. So with the Fidelio, they basically, the patient fits the criteria. They randomize to phenylalanine 10 milligram or 20, depending on the potassium and AGFR, comparing to placebo. So the baseline characteristic, the mean AGFR of 44 and the ACR of 852. So as we said, it was more predominantly CKD 3 and 4. 80, almost all the patient on the maximum tolerable dose of ACE or ARBs, the compliance was and the adherence was really high, 92%. The median follow-up was 2.6. And you can see here the primary kidney outcome. For the sake of the time, I'm gonna, it's written there like what's the primary, but for the sake of time, just I will go a little bit quickly. So there was 18% reduction in the primary kidney outcome on the top of the maximum dose of ACE or ARBs, and number to treat after 3 years, 29, which is significant. If we look at the albuminuria, there was significant reduction by 30% between baseline and 4 months, and it continues through the study. Our patient had 27% reduction, which is almost the same. Again, if we look at the secondary cardiovascular outcome, there was significant reduction by 14%, number to treat after 3 years, 42 patients. Regarding safety and safety and other side effects, it was almost equivocal to the placebo group. If we look at the blood pressure, there was a little bit reduction. As we said, it will have some reduction in blood pressure. The maximum was 2 to 3 millimeter mercury, which in some cases really it's a plus. And also change in hemoglobin A1C over time was similar to placebo. Of course, there was a predictable impact on serum potassium, but if you see here, the hyperkalemia was not really that significant. The difference, maximum difference, was 0.2 millimole. This is something really to consider, something to really monitor, but I don't think should really be a barrier for us to use such medication with benefit of mortality and morbidity. And we will talk about it more. Basically, you can see here the discontinuation regarding and hospitalization regarding the hyperkalemia was not statistically different. And as we said, this is something to monitor but not to prevent us from using such medication. This patient, as we said, her potassium was 4.6. Her eGFR was less than 60. So we started with 10 milligram. We monitored the potassium. Usually by the study, it was at 1 month. But in some cases, if you prefer to monitor it a little bit more, especially with the GFR lower, this one we monitored over a couple of weeks, period. It was fine, so we increased the dose to 20, and we will see the next time we will check her albuminuria and see what's going on. So this is the scheme where, like, you start, you monitor. If the potassium go above 5.5, then you need to hold the medication and wait till it goes less than 5, then you will start with 10 milligram. Even if you were on 20 milligram, you start with 10 milligram, and again, you monitor and you adjust accordingly. With the Figario, again, our patient comes with where the arrow, so it really fits the criteria for the Figaro study, where the primary is cardiovascular. And you can see here on the right side, predominantly stage 1 to 2 CKD, decrease in cardiovascular mortality and morbidity 13%, and decrease in CKD progression by 13%. This is again on the top of the reduction of the ACE or ARBs. So that's the reason now with the 2 study, it's really covering the whole spectrum of CKD in type 2 diabetes from 1 to 4. And as a primary care physician or internal medicine, we see such patient, especially in the stage 1 and 2, and maybe to a degree 3. So we have to do every effort to really prevent them to go to the nephrologist as much as we can. And we talked about the pre-specified meta-analysis, the Fidelio. This is like looking at the whole population. You can see there was 14% reduction in cardiovascular morbidity and mortality, 23% reduction in CKD progression. Again, those are very impressive numbers. We should really get our patient to get the benefit of such medication. Also, you can see phenylalanine significantly reduced the risk of cardiovascular death and first heart failure, hospitalization to heart failure, remembering that the patient, the HFrEF was exclusion criteria for those medications. So most of the patients, they didn't have heart failure, or maybe they have HFpEF. The majority of the patient was not on SGLT2, only 6.7%, but in the analysis, the benefit was for both on patient on SGLT or SGLT2 or not, and also similar in different categories of eGFR. Finishing with the international guidelines, now it's really level A or 1A in most of the guidelines, so there is no controversial issue about that it's beneficial for our patient. Even with the European Society of Cardiology 23, also it's level 1A. Also in the updated 23 ECS heart failure, it comes as 1A for prevention in heart failure and CKD and type 2. Now it's the label is updated. It used to be a little bit difference between US and Europe, but now it's updated to cover stage 1 to 4. And nowadays, really, we're talking also about CKD prevention, as we need to have the 3 pillar, which is RASI inhibitor with appropriate dose, and non-steroidal MRA, which is phenylalanine. There is no other medication at this time except phenylalanine and SGLT2. Of course, we have to control the blood pressure, the blood sugar, and all of this. So in conclusion, CKD is very, very dangerous when we combine it with diabetes. I showed that at the beginning. We should screen our patient. We should treat our patient, not just to screen and wait or wait till they get worse. It's a effective medication. It has some side effects which can be manageable and monitored. And again, we really need to start using the 3 pillars. And of course, regarding hyperkalemia, it's not excuse anymore just to deny the patient the benefit of all those medication, because we have a solution, which is the new potassium binder like Patoramir or Zirconium. because again, the benefit outweighs the risk, and we should help our patient to survive more. Thank you.